Welcome to the Digital Health and Innovation Podcast, a publication of the Southern Medical Association. This podcast will educate and inform listeners on the various systems and methods that use information, data, and communication technologies to help resolve problems, reduce inefficiencies and costs, improve access, increase quality, and help make the practice of medicine more personalized and precise.
Welcome to SMA's Digital Health and Innovation Podcast. I'm your host, Dr. Andy Mohan, SMA's Digital Health and Innovation Chair. Today, we are discussing testing for COVID-19. We're joined by the Vice President of Applied Research and Technology for Abbott's Diagnostics Division, Dr. John Hackett. Dr. Hackett manages diagnostics, research and development in the areas of infectious disease, oncology, cardiovascular, metabolic biologics design and discovery, and clinical chemistry. We are also joined by Mr. Jeremy Schubert. Mr. Schubert has dedicated his entire professional career to Abbott, joining in 1993. He has held several commercial and leadership positions across multiple divisions of Abbott, including Managing Director for Northern Europe and Divisional Vice President of Latin America and Canada. Jeremy assumed his current role as Divisional Vice President for U.S. ADD Commercial Operations in 2017. Finally joining us today is Dr. Deepak Mohan, Medical Director of Pathology and Clinical Laboratory at San Joaquin General Hospital in French Camp, California. Dr. Mohan will moderate our questions for Dr. Hackett and Mr. Schubert in order to help us gain a better understanding of this topic and to clear up the common misconceptions and confusion around testing for COVID-19. Gentlemen, it is an honor and pleasure to be with both of you today. Dr. Mohan, please go ahead and lead the discussion with your first question.
Thank you, Andy. COVID-19 has profoundly affected all of our lives throughout the world. And as a pathologist, I know the only way that we can lead ourselves outside of this situation is through testing. Unfortunately, testing is not that simple. I've been a medical director for 15 years, and it's extremely difficult to determine what is the right test to do and the right time to do it. In this particular crisis, the FDA has been inundated by over 300 applications for emergency authorization to be able to offer a test. Now, there are companies out there that are fraudulent, that have not even been FDA approved, and they claim they've been FDA approved and trying to send out their test for people to use. How do we know what's a good test? Not all of us are pathologists. Well, it's fairly simple. You go with a reliable company who's been doing it for a long time. Today we have a great guest. We have folks from the Abbott Diagnostic Laboratories group who have been doing this since 1888. Now, to put that in perspective, that's 4 years before Coca-Cola served up their first soft drink. So that's an amazing legacy. And since they've been doing it very well. They're a Fortune 100 company. With that being said, we have a great treat today for you. We're going to have some information that can help all of us get through this COVID-19. And as I said before, testing is the way through. So let me start it off by a question for Dr. John Hackett. What are the different types of tests that are available for COVID-19 today?
Well, Dr. Mohan, thank you for the nice introduction. As a leader in diagnostic testing and with a long history of developing tests, from Abbott's perspective, we look at this as really no test is really going to be enough on its own. And when it comes back to the basic types of tests which are used in this case, one category we would call, in general, molecular tests that actually can detect active infection. And we can go into more detail of that later. But in general, for those tests, you're trying to detect nucleic acid associated with the virus. And then there's serologic testing, which can provide evidence of recent or past infection. So in this case, for example, detecting antibodies to the specific virus that you're interested in that essentially are created by the human body and generated in response to infection with the virus, such as SARS-CoV-2. Now, there is one other technique that can be used for direct detection of the virus that we consider a serologic assay, and that would be detection of antigen associated with the virion itself. So again, that would be direct detection of a part of the virus, in that case, protein.
Another question for you, Dr. Hackett. Which of these tests are available from Abbott today?
Well, for Abbott, we followed a strategy first recognizing the importance of detecting active infection. And so the very first test, which we received emergency use authorization for, was the real-time SARS-CoV-2 test on our M2000 platform. This is a laboratory-based instrument where one uses RT-PCR to amplify the viral genome so that you can detect it. And the second test, which we had EUA on, was the ID Now. Now, this is a platform which is a point-of-care instrument, very small instrument, mobile, about the size of a toaster. And that can generate a result anywhere from about 5 to 15 minutes. And again, this is a technique which is used, it's isothermal, but again, it amplifies the genetic material that's present within a sample if it's infected. So that was really our first strategy, was to go to what we knew could have impact at identifying individuals who actively had infection. Of course, it was so important to do that in order to get them into appropriate medical care, to do quarantining where we need to do contact tracing for a highly transmissible virus such as SARS-CoV-2. We then went on to focus on serologic tests. And so the next test, which we developed, was on our laboratory platforms, the Architect and Alinity platforms. These are high throughput instruments, again, focused in laboratories, which could be in hospitals, reference laboratories type settings. The first test we developed was an IgG test, so that would detect antibodies that were created in response to infection with SARS-CoV-2. We're currently working on an IgM test, which would detect a different class of antibody. It's associated, in general, responds a little more rapidly than IgG, although it doesn't appear there's a large difference here, but it doesn't stay in the system as long. So it has value because we can see it rise, and then over probably a 6 to 8 week period, the levels of IgM would decline. Whereas for IgG, those levels have the potential to persist. And we know, I mean, we've seen evidence now, certainly out to a few months, and those antibodies in some cases can persist for years. It still remains to be determined for this virus, as we're still early in the cycle of understanding it. And then we also are actively working on lateral flow tests, which that would be point of care antibody tests, which again, different setting. This is going to the patient rather than to a core laboratory, for example, in a hospital or a reference laboratory. So again, our view was no one test was enough. Get a repertoire of tests that we could have essentially where the people are. So for when you need high throughput testing, having that on these laboratory instruments. For when you need a point of care testing, to have it on the point of care platforms. So broad portfolio of tests.
So Dr. Hackett, you mentioned the point of care test. The Abbott Now specifically has been in the news recently. What should physicians know about the accuracy of this particular test? Because it's been questioned.
It has been in the news, and there have been a number of different issues that have arisen. Certainly this test, the ID Now test, if used as it was intended to be used, which is a point of care test, taking a nasal swab or oral swab, putting it directly on the instrument, it certainly performs the way it was supposed to perform. In some cases, there were situations where individuals were diluting essentially doing a dilution by taking that swab, putting it into a virus transport media, and then testing it. And there was a case recently with NYU investigators, and really as one examined that work and Abbott individuals talked with these researchers, this was not a well-controlled trial. It turned out, as you can tell from the publication itself, it had a very biased population in terms of CTs, an extraordinary number. I think 45% of the samples they tested were CTs greater than 38. So this is associated with extremely low levels of virus and may not even be active virus at that point. It could well be residual nucleic acid that was present in those samples. So this test overall has performed well. Dr. Po Tu from the Abbott Clinic in Seattle had presented data a couple of weeks ago, and in their study, they saw 91% sensitivity with the test and 100% specificity. And overall, the studies have been ranged from the mid-80s to the mid-90s in terms of sensitivity level. So it's a very effective test when it's used as it should be used.
So Dr. Hackett, as you know, majority of our listeners are family practice physicians and in basically primary practice fields. When ordering a COVID test, what considerations should they know before ordering the correct test?
Well, it really comes down to, I would say, a couple different factors. The first is, what are you intending to use it for? Again, if you're looking to diagnose active infection, then the appropriate type to test is one of these nucleic acid tests. Depending on your setting, whether it is sent to a laboratory or, for example, you have ID now. I mean, that is the type of platform that can be used at small centers and urgent care centers. These types of deployments are common. For direct detection, these are the types of tools that you want to use. Later in infection, or if there's questions over time from that time of symptom onset, 2 weeks later, 3 weeks later, 4 weeks later, really antibody testing becomes important. And when you're thinking about antibody tests, it is extremely important that one considers the sensitivity of the test, but also the specificity of the test. And there were concerns early on. There's certainly been a great deal of press around the inaccuracy of some serologic tests. There are tests out there with specificity that maybe 95% or less. The Abbott test is greater than 99%, and in fact, 99.6% or higher. And so that's a big difference in terms of the overall reliability of results one's going to obtain. And we've already seen demonstrations of that with the Architect test, where it's been used, for example, in serosurveillance, where researchers have used control populations, looked at specificity, and then been able to use it in order to identify infections in their population. So it's different types of tests. As the IgM tests become available, I believe this actually will be a added asset. There's the dynamic between when an individual is first infected. Typical onset of symptoms is probably 5 to 5.5 days. It's the median overall. Virus actually peaks if you're looking in nasopharyngeal, nasal cavity, about 1 to 2 days later in general, and then starts to decline. And so again, that time from when an individual may have onset of symptoms, which sometimes can be really mild, but the longer that period of time that you go, certainly as you get out to 13, 14, 15 days, the nucleic acid test becomes less reliable. And it's probably a combination of factors in terms of the amount of virus that's available for sampling in the nasal cavity, and even maybe reproducibility of the sampling process itself. But there's where serology certainly could be a valuable adjunct to understand whether that patient was infected. I mean, if that's when they present to you, it may be difficult to get a reliable nucleic acid result after that period of time.
Let me ask a follow-up question to that. This comes up very frequently with our patients. We have a patient that says, hey, I think I may have had it about 2 weeks ago or 3 weeks ago. Very mild symptoms, didn't get a PCR test at the time. Is there any way I can find out for sure if I had COVID-19 or not? And, if the test comes back positive, am I immune?
So at present, that isn't really known. This, in general, as one raises an immune response to a virus, you generate antibodies, which can be protective. In this case, we really don't have sufficient data to indicate whether antibodies are protective or what's the duration of protection that might be afforded by them. Now, there is some data that's starting to be generated. There was a recent publication looking at an experimental model of rhesus macaques, where after a month, they tried to reinfect these macaques and weren't successful. So it did appear to provide antibody. It did appear immunity appeared to provide protection, but there's still more data needs to be generated. I think from a perspective of antibody testing and how it could be used at present, certainly there are many people who would like to know their status. I have many people, saying I'd just like to have a test and know if I was. It's certainly a way of identifying individuals who have had an immune response to the virus. And as we think about high risk settings, so healthcare workers, nursing home workers and individuals in nursing homes, and other essential first line employees, these are groups which we're seeing increasing use of antibody testing. For looking at seroprevalence, this is a really interesting dynamic which will play forward. We know relatively little about this virus at present, and we're learning a lot daily. But I can tell you that one set of experiments that we were involved with, which was using the Architect SARS-CoV-2 IgG test, looked at blood donors in San Francisco and saw very little right there. And yet we were involved in another study in a small district in San Francisco, which had surprisingly high cumulative prevalence. So there was a combination of using both molecular tests as well as serology tests. And what it revealed is that, you can take an overall perspective of the population, and yet if you really don't drill down, in this we saw that there really was, higher prevalence in a specific ethnic group. And so, there's going to be a very different picture in different settings, I believe, as we move forward in this. And it is important to understand what populations have been impacted by this.
That was an extremely good answer. I'm very pleased with the thoughtfulness that you put into that answer. I do want to ask you one more question before I go on to Mr. Schubert. Now, you did mention about IgG as well as IgM tests, and I know there are other products on the market that combine both IgG and IgM. Could you just briefly describe the merits of IgG being separated from IgM? What is the benefits of having both tests available, and some more details regarding both of those?
So, yes, there are multiple different formats for detecting antibodies, and one format is that you could detect total immunoglobulin. So this would detect IgG, IgM, and IgA if it were present in blood as well. The other alternative is to look specifically for IgM antibodies or IgG antibodies. The real advantage, I believe, of being able to separate the two is that IgG gives you a readout over time, in essence. So if you have an individual, the IgG response is created, and IgG antibodies tend to be far more durable. It lasts in the system much longer, in the blood much longer than IgM antibodies do. So again, when you have these difficult situations in terms of managing patients who may be presenting quite a long period after they had onset of symptoms, having both IgG and IgM allows you to understand if that IgM is present, it is indicating more recent infection versus the IgG, which may last for a much longer period of time. And I believe as we dial forward, so certainly I think from that perspective, it is very valuable. The other consideration is time here. I mean, as this pandemic plays out. We had a starting point in the U.S. of the very first case in the end of January that was identified here. Really, in a very short period of time, we have this short window. If we start seeing spikes over time, so if we dial forward 3 months, 4 months, 6 months from now, it'll be really important because IgG, if that was all one was looking for, or total Ig, you could tell a person was infected, but you would have no idea whether or not that might be a recent infection. And so being able to come back and use IgM as well as IgG will help as we dial forward in differentiating between these types of individuals. And certainly as one thinks about contact tracing and preventing spread, this could be a real advantage.
So the next question is for Mr. Schubert. I see that you have a public health background, Mr. Schubert. So I have a question regarding the public health viewpoint. I'll make it very open-ended. Why do you think serology testing is important for the public health viewpoint?
Yeah, thank you. That's a really important question to ask because as we think about COVID-19 is a public health problem. But if we juxtapose that to the construct of our U.S. healthcare system, we're kind of trying to deal with a public health problem primarily through a healthcare lens. And although healthcare and the healthcare system is an important part of the public health system, it is not in and of itself the kind of totality of public health. So we really have to think about the broader picture because from a healthcare perspective, we have to take a broader role and step in kind of to this public health realm. And so if we kind of take a step back and we think about kind of pandemic 101, there are two axioms that come to mind. The first is that you can't stop what you can't see. And so a lot of our challenge with managing COVID-19 is really getting a three-dimensional lens about where it is and where it's headed. Secondarily, there's the axiom that effective treatment begins with effective diagnosis. Well, if we kind of take that and put it on its head in pandemic language, effective pandemic management begins with effective longitudinal comprehension of the infection's location and its migration pattern over time. And so if that's really kind of how we have to think about it from a public health perspective. And generally, we're kind of looking for two things. We're trying to understand effectively distribution across multiple domains, and we're trying to understand causation. Now, distribution has a couple of components, being the distribution of the outcomes, how people are doing, but also distribution of the exposures, whether that is to the virus itself, to some environmental factors, to some social determinant. And within that distribution, we're kind of looking at it through three different lenses. We're looking at the demographic side, which is going to actually play out to be much more important than maybe we were considering going in. And so the demographic is not just kind of who's been affected, but what's that social demography that actually qualifies them for? So what ethnicity, what zip code, what family situation are they in? What environmental situation are they in? Then we have this other swim lane of the geographic. So where is this happening? And most importantly, are not to be belittled in this distribution element is time. And it's not just where we are at any given point in time, but it's about being able to look at the change over time in a population and in individuals. From a causation perspective, we're kind of looking at two domains. We're looking for, what are the potential things that are causing or accelerating virus transmission? But by the same token, we're also trying to understand what is the impact of the interventions that we can take, like social distancing, for example. And so those are kind of the things that we're trying to measure. Now, as we get back to the role in public health, and again, just infectious disease 101, we're really searching for this kind of element of herd immunity, which is no more complicated than saying we're going to be breaking this chain of infection transmission over time. And as we do that, then that's how we either get the virus under control or keep it to a very minimum impact to the welfare and well-being of a population. And so as we kind of think about this herd immunity and we think about the impact of COVID, one of the best ways to think about it is the basic reproductive rate, which many will know that this is just how many people one person's likely to infect. And although COVID is often compared to the flu, it really is not it's a fair comparison in terms of symptoms, but where it starts to differentiate is this basic reproductive rate, because the flu reproductive rate is somewhere between 1 and 1.5, where COVID is 2 to 2.5. Now, that may not sound like a big deal. However, when you actually play, let's say, 10 rounds of transmission, one person can infect over 2,000 people, or can be the genesis of that. So, understanding kind of what's happening in the herd, so to speak, and locating where the virus is and how it's moving is really important. So it's not, if we look at the traditional healthcare lens of just what's happening with this patient, it's us being able to understand the complete ecosystem that's surrounding a patient in an environment and doing something about it. So in short, as you think about serology as it relates to public health, it's a pretty nice tool that can help us understand distribution much faster, much cleaner, even much cheaper. So it can help us understand the demography. It can help us understand the geography, and as we look at it, it can help us temporally get a baseline and look for changes over time. It can help us locate causation. So everyone on here is going to be very familiar with the concept of contact tracing. At its core, that's what it comes down to, is being able for us to even figure out where has an infection taken place, and can we work ourselves forward or backwards. It may help us identify the driver for where transmission is taking place. Perhaps it's going to help us actually mitigate causation. Perhaps, using in certain ways, it'll help us assess the strategies that we're putting into play in communities where we can see the chain being broken and epidemiologic distance being created. And maybe it could be one of these things that as we go through and gather more data, it'll help us discover other elements other interventions we might be able to put into play to effectively create epidemiologic distance and get ourselves to kind of a protected herd, so to speak. Finally, it helps us assess the herd in general. Perhaps you couldn't argue, as Dr. Hackett said, given the data, that you've got complete herd immunity at this point, but it at least kind of helps you start to understand the epidemiologic distance within the herd and kind of the overall well-being of the herd.
Mr. Sherwood, that was excellent. I really enjoyed that. I do have a very specific question. It probably would be in everyone's minds. Of course, we all watch the news and we see many of the nursing homes around the country being affected by this disease. What role does serological testing have in these kind of high-risk populations?
I think it's a really good question, because it's well documented that COVID-19 has significant physical impacts to patients with certain pre-existing conditions in the older part of the population, and concerning. And if you have a grandmother, you're worried. And so I'll give you just two things to think about as it relates to how we want to use serology, or think about serology as a potential value moving forward. One is that there is an element of helping understand the patient and the patient's environment. Being able to see or detect if somebody, one of these patients has had or has come in contact with COVID-19, it would be some useful information to have. And I would expand that kind of even to understanding their environment. All of us have seen on Facebook or some news story where some 3-year-old granddaughter is having to talk to her grandmother through the window. And although it's not an advocate to say, testing is going to enable families to reunite, it's not what I'm saying. The fact that there is a lack of data, a lack of understanding of someone's exposure to COVID creates a dynamic where that's a sad picture to see. And so serology offers a potential, and I want to underscore potential as we kind of go forward. Look at really understanding the environment that not only has someone been exposed, but the environment of people around them that potentially have been exposed to COVID. A second thing that I believe is something to consider as we, particularly as we think about moving forward, is the temporal element that's associated with all patients, but specifically those that are high risk. And what I mean by that is, we're all going to enter this strange dynamic where we hit flu season, and where every fever and cough is going to be met with consternation. Is this a cold? Is it the flu? Is it COVID? And although the data hasn't caught up with what exactly does having antibodies fully mean as it relates to immunity, there's going to be a different circumstance you're going to sit in come October, November, when you're staring at a patient who's already been tested positive for antibodies to one that has never had a test whatsoever. And I think having that more information as you have as a starting point, given how the science will progress and catch up, having that baseline is going to be more beneficial than not. And so as you think about for this high risk population, gathering a baseline now, could give you some significant value as you start to hit into the flu season, particularly when you get to a point where these may be patients that you don't see again until something arises, like I have a fever, I have a cough, I feel heaviness in my chest, and having a little bit of a baseline information going into that conversation as a physician, as a clinician, might be beneficial.
That's excellent. Mr. Schubert, you mentioned earlier about the social determinants of health and COVID testing. Could you relate that concept to let's say, our rural population in the South?
Yeah, so as Dr. Hackett said, there's kind of emerging data that's showing that COVID impacts populations kind of unequally and social demography unequally. And I want to pause here because that can end up spiraling into a conversation about inequalities in the U.S. healthcare system, and it's not that at all. We have a good system in the U.S. and one we can be very proud of. For sure, there are opportunities to make it better, but this is not COVID is not an indictment of the system. There's just certain social demography that plays into the hands of the virus, whether it's families that have 10 members that are living in the same household or in close quarters, whether you live in a high-rise apartment building with thousands of people that are in it. There's this kind of these social elements that come into play that are going to affect the prevalence, incidence and prevalence of the virus across certain populations. And so one of the things is you start to think about even rural populations, but just in any general populations in the South, some of them are going to be unequally impacted. And again, thinking about this temporally, right, one of the things that we want to make sure that we're considering is how are we understanding and maybe being, I would say, proactive with the populations whose social demography may have put them at a higher risk of either having or having had the virus or getting the virus when we have wave 2 or flu season or however this ends up migrating in the future. And why I say that is, again, much similar to the high risk population. It's thinking about, how do you proactively go track baseline, not just for having the data's sake, but for then being able to, given the social circumstances of the patients or the people that you're dealing with, what's the best way we can be, good healthcare advisors for those populations, and based on the testing information that we have. So for a household of 10 people, 5 of which who have antibodies or have tested positive for antibodies for COVID, and 5 who are testing negative, that's a whole different circumstance in terms of how that household will need to manage someone in that household who is sick than if all 10 people tested positive to if no one's tested positive. And so there's an opportunity for physicians to be really good clinical and life advisors for their patients and the people that they're serving for their communities, if they kind of understand how the social determinants may facilitate transmission of the virus and eventually facilitate some inequality of care downstream. I think what we got to look at this as is a way for us to get out ahead of wave 2, and particularly get out ahead of where these social determinants may exacerbate current inequalities of care. And I think if we do that, we look forward, we can get prepared, we can react quicker, better, stronger as a healthcare system.
Excellent. Thank you so much. I have one last question, probably one of the most important questions. And as a physician, I get this question quite a bit. A lot of us, fortunately, in the healthcare field have been able to work, but there have been people laid off in other fields, as well as the educational area where my children are not at school, and universities may or may not start in the fall. I wanted to know what your thoughts are. How would you have physicians engage in this process to help initiate testing, to help people get back to work and get back to school? Do you have thoughts on this, Mr. Schubert?
Yeah, I can give you a couple things to think about as it relates to this. And I would go to kind of a higher order perspective here, is starting with how we look at the definition of health to begin with. Historically, we've thought about health mostly as kind of a physical situation. I get sick, I get better, I get hurt, I recover. And it wasn't until the late 90s that really mental health started to lose some of its stigma and get brought into the whole equation. But I would expand that to where we're at today, of thinking about health even beyond that, in terms of spiritual, emotional, sexual health, right across the board, being treated as a whole person. When you take that into consideration and you kind of think about the impact that COVID has had in a broader sense, it's for sure devastating physically to a number of people and to their families that are impacted by it. But it also has a very weighty emotional, mental, spiritual health impact on people in terms of the worry and the concern it creates, and effectively this sense of limitation and separation that social distancing creates, and then sheltering in place creates. And I say all that to say that you can never underestimate the mental and emotional side of someone's wellness and their sense of safety and their sense of security in terms of going about their day-to-day life. And as you start to think about this institutional testing, as I will call it, whether it's return to work, return to school, return to the park, however you might kind of lay that out, it is an emerging kind of sense, because people want to feel safe. And I, as a father of two little kids, I want to know when my kids go to school that they're going to a safe environment, and that when they go visit their grandmother and their great grandmother, who's still alive, thank God, that they're not putting them at risk. And so I say all that to say that we're going to have to grapple with, as a society, as a community, how we do this. What we're hearing is, several employers, several universities are working on testing strategies for how they're going to understand the state of the populations that they're working with, and more specifically, how they're going to support those populations if there is some sort of, if there is someone who has COVID-19 or just is dealing with the stress of it. And so, I believe this is something that we're all going to have to pay attention to. And although clinically and mathematically we can minimize it as a value or as realistic, what's important overall is that we've got to participate in helping our local communities feel safe and feel like they're okay to go outside, they're okay to go to the restaurant, they're okay to go to a place of business, they're okay to go to work. And as clinicians, as a community, we've got to think that through. There will be some sort of mechanism in play that, at least over the short run, begins to facilitate people getting back to work in this institutional kind of play. I don't know how long it will last. I don't know how robust it will be. But by the same token, I do believe it's important, because we all need to feel safe when our kids go to school, and when we walk into the office, when we go to a restaurant, when we live our lives in our community.
That was truly excellent. Thank you very much, Dr. Mohan, for leading this discussion. Gentlemen, before we wrap this up, I would like to personally thank Dr. Hackett, Mr. Schubert, and Dr. Mohan on behalf of the Southern Medical Association for taking time to discuss this very valuable topic for our listeners. Additionally, I would like to also thank our listeners for tuning into this thoughtful podcast. During these difficult times, I would like to say God bless you all, and please stay safe. Thank you.
Thank you for joining us. To subscribe to additional podcasts, visit sma.org/podcasts.